cancer cases over a 5-year period, with breast cancer accounting for more than 38% of all female cancer diagnoses and prostate cancer making up 30% of male cancer cases. Your health is your greatest asset. And that's why Business Day Television invites you to our monthly health webinar, where we bring vital health conversations closer to you. Join us Thursday, 9th July, as seasoned medical experts discuss the cancer conversation, prevention, early detection, breast and prostate health. Gain practical insights, ask your questions, and learn how early action can save lives. Because every life matters, every health conversation counts. Scan the QR code to register and be part of the conversation right here on Business Day Television.
As Nigeria stands at a critical turning point, we move beyond the conversation of mere survival. This year, Business Day presents the 2026 edition of the CEO Forum, themed From Stability to Shared Prosperity. Join the nation's most influential CEOs, policymakers, and business leaders with keynote insights from Taiwo Oyedele, the Minister of Finance and Coordinating Minister of the Economy, and the Central Bank Governor, Olayemi Kadoso, alongside a powerful lineup of voices shaping Nigeria's economic future. Happening on the 16th of July 2026 here in Lagos. For more information, call Uchenna on 0809 645 3535 or Shegun on 0812 024 3167 or Daniel on 0802 756 4653. This is not just a conference. It's where conversations become decisions that shape the future of business.
Hello, everyone. Good afternoon, and welcome to our first edition of Health Matter Business Day Television's webinar series, where we bring together experts to discuss some of the pressing health issues affecting our society. My name is Deborah Eze, and it's a pleasure to have you all join us, and I'll be moderating this webinar this afternoon. You know, growing up, many of us heard that prolonged exposure to the sun, certain foods, smoking, or unhealthy lifestyles can cause cancer. While there is some truth to some of these risk factors, cancer is far more complex than many people realize. It is not a single disease, but a group of diseases influenced by genetics, lifestyles, environmental factors, age, and even access to quality healthcare. The encouraging news, however, is that many cancers can be prevented, detected early, and treated successfully when action is taken in time. Here in Nigeria, cancer continues to pose a significant public health challenge. Breast cancer remains the most common cancer among women, while prostate cancer is one of the leading cancers affecting men. Yet, many patients still present at advanced stages when treatment becomes more difficult. And that is why today's conversation is so important, and the primary reason, why we are gathered here. Today, we'll be discussing the cancer conversation. We'll be looking at prevention, early detection, and breast and also prostate health. We'll explore the realities of cancer, separate the myth from the fact, discuss the importance of screening, and examine the latest advances in treatment and also care. So whether you're joining us today as an healthcare professional, a patient, a caregiver, or simply someone who wants to learn more, we encourage you to stay with us throughout this conversation. And of course, we would love to hear from you. Please drop your questions in the comment section, and we'll make sure all of your questions will be answered during the live Q&A session. All right, enough of me. I am not the speaker, rather neither am I a doctor. Now let's meet our distinguished panel of our experts, our doctor experts. And joining us today are 4 distinguished healthcare professionals, each bringing a unique perspective to cancer care journey. All right, let me introduce them in no order. On the panel today, in no particular order, we have Dr. Abib Moshood. He's a physician, healthcare strategist, public health advocate, and executive director of HCA Consult. He's committed to advancing healthcare delivery, innovation, and sustainable development across Africa. And also we have Dr. Adefusi Temiloluwa. He's a third-year resident in anesthesia and intensive care at Lagos State University Teaching Hospital, Ikeja. He currently serves as an associate editor for the Nigerian Journal of Clinical Medicine and is a reviewer for several notable medical journals. And also we have Dr. Aladesuru Olumide. He is a general surgeon and surgical oncologist. And finally, we have the only lady amongst the panelists. We have Dr. Akimbami Omobolale. She's a consultant oncologist at General Hospital Isolo. All right, before we give the floor to our speakers, our wonderful audience, please remember to leave your questions on the comment section. Every questions concerning this conversation will definitely be answered by our speakers. Good morning, this afternoon. All right, let's get into it. All right, so I'll be starting off with one question that will go around our panelists. And the question is, what is the biggest misconception that Nigerians have about cancer? And I'm going to be starting off with Dr. Abib Moshood. Dr. Abib, you have the floor.
Good afternoon, everyone. It is really nice to be here. Thank you, Business Day TV, for putting this together. So the biggest misconception, I'll look at it from a culture perspective, right? So people present late to the hospital because when they notice something in their body, something unusual, right? They try different orthodox means of, try to get it out and all that. So the health-seeking behavior in this part of the world is not really encouraging enough. So culturally, people believe that once you have cancer, it's a death sentence. Once you notice anything in your body, don't go to the hospitals. Those doctors are going to cut any part of your body away. So it's better to just take herbal concussion to just get it out. So that's the misconception that has really affected, because when people present early, when we discover these things early enough, the prognosis is way better than when it is discovered late. So a misconception would be thinking that whenever you notice anything unusual in your body, seeking medical attention will give you a worse outcome than trying other means. So that's the misconception I wish people can that we can debunk as far as cancer care is concerned in this part of the world.
All right, Dr. Olumide, we would like to hear your thoughts concerning the biggest misconceptions that Nigerians have when it comes to cancer.
Hello, can you hear me?
Very well.
All right. Good afternoon, good day, everyone. Thanks for giving us the opportunity to share this forum. The biggest misconception I perceive from my patients, definitely as I introduce them into the management and give them information, is the first thought that this is cancer, that means I'm going to die. It's cancer, it definitely equates death. So if I'm going to die at the end of the day, why do I have to bother going to the hospital? Why do I have to bother spending to get care? If I will just die at home, why will this be wasted on me? I've seen elderly patients that says, I'm actually in my 70s, I'm in my 80s, I'm close to the grave. Now I have on top of that a cancer diagnosis. I'm going to die anyway. So just allow me be. So that's the first one, misconception that cancer is death. Another one is that cancer is a waste of money. Cancer care is a waste of money, which actually tallies with the first point, that this is cancer, I'm going to eventually die. So why do I have to bother doing a lot about myself at this moment? So definitely these are things I observe very frequently in the cases I manage. And I play my role most times to make sure that these patients are well educated, given the proper information, guided by the principles of practice, guided by the proper expectations of care, based on the condition in which I'm seeing them and what can be offered as the care options? Is it going to be the medical drugs? Is it going to be procedure or whatsoever? So these are some that may, you don't have the full confines of time to explore, but these are some of the ones that I have seen in patients, and I try to intervene to the best of my ability.
Right, Dr. Adefusi, you have the floor now. Share the biggest misconception that you think Nigerians have.
Okay, first of all, I like to say that because I have a quite spiritual background, one very big misconception Nigerians have about cancer and cancer diagnosis is that, first of all, it's spiritual attack or spiritual affliction. So you hear stuff like off our knee, that kind of stuff, or you hear the fact that it has to be from spiritual realm, or even if at all it's showing physical signs, it has spiritual connotation or spiritual origin, that kind of stuff. Also, another very common misconception, especially for procedures that you now have to, because I actually have seen a couple patients that presented early for this for screening, discovered the cancer diagnosis early, but then when you tell them that they have to do surgery, they feel like, no, this is a death sentence. So that's the other issue they have. Aside the fact that some people are highly spiritual in their beliefs, the fact that, or some people also believe that if they have to do surgery, then the possibility of them dying is very, very much likely.
Thank you very much, Dr. Adefusi. And of course, we have to hear from the lady, Dr. Omobolale. What's your thoughts about the misconception that Nigerians have when it comes to cancer?
Yeah, thank you for having me and for creating this platform for awareness to the public. Basically, just like every other speaker has said, aside the fact that the majority of times, from my experience, a lot of patients do truly believe that cancer is a death sentence, and that actually has caused a lot of them to present late. Aside that is the fact that they believe that the only treatment for cancer is through the use of chemotherapy. And from their own perspective, they feel chemotherapy kills. So when a patient presents to me and we give them the options for treatment, and one of it is with the use of chemotherapy, they immediately object to it, and they would rather die than, go through chemotherapy, or because of the untoward side effects that you've seen maybe on social media, patients being posted while having treatment. So although with all certainty, we know that chemotherapy has side effects, and as physicians or as oncologists, we tend to allay their fears, and we also make them understand the fact that there are protocols, there are necessary things that are put in place to ensure that chemotherapy does not present or give them those untoward side effects. And if at all those side effects occur, there are things put in place to help control those side effects, as it were. So for many patients, chemotherapy actually saves lives and significantly helps to prolong their survival. So another myth is the fact that only people with a family history develop cancer. Majority of times, cancer occurs sporadically, and the family influence, the family history influence, or the hereditary influence may only occur in about 0.5 or 5% of cases. So majority of time is not linked to any hereditary or family history for a patient to come down or develop breast cancer. So these misconceptions overall help kind of like delay diagnosis and treatment. And unfortunately, delay is one of the strongest predictors of poor outcome.
Thank you very much, Moblani. I like how different perspective was actually given, to a general question. But let's now transit from the general question and examine how, each specialist contribute to a patient's cancer journey. And of course, I'm going to be starting off with the family physician, Dr. Abib Moshood. Okay, we understand that family physicians are essential, the first point of contact. You guys are usually the first point of contact. So what subtle sign or symptom should never be dismissed? And how can primary care, I beg your pardon, play a greater role in detecting cancer before it reaches an advanced stage?
All right, thank you very much. In this part of the world where we don't have a lot of healthcare professionals compared to our population, not to now mention specialists, family medicine physicians are also specialists. Don't get me wrong. But for general practitioners, they are probably I like to call them like the frontline workers, right? Because you see them in your PHCs, you see them in most of your hospitals. So one of the signs, it depends on which part of the body that we are referring to. So if a woman presents and say, "Oh, I noticed a lump in my breast," right? So that's something that should be taken very serious, right? If another person presents with this abdominal pain that you just can't seem to understand what exactly is going wrong with this abdominal pain, that requires, paying extra attention to. So there are many more, right? Something just unusual beyond the so common things occur commonly as they would say. So anything unusual, we get to pick it on time and then press further to get to know what exactly is happening and refer to the appropriate specialist or appropriate facility. Referral is a major part of medicine too. So I usually tell patients, I usually tell the populace, if you notice anything unusual, don't keep quiet. It's difficult to maybe see a specialist in last note. Go to any hospital that is close to you. Still get to see a doctor, right? So the doctor can still try to find out what is wrong and refer you to appropriate place where you can get proper care. So if you ask me from my own perspective, the most important thing is when patient presents, if there's anything unusual beyond what we see commonly, right, we press further to get to know what is happening and we refer the patient to the appropriate specialist. Yeah, that's it.
All right, thank you very much. Let's now move to our consultant oncologist, which is Dr. Omobolanle. Now, this is for you. In your experience, speak to us about the single biggest factor that determines whether a patient survives, between timely diagnosis, access to treatment, and also advances in medicine. Dr. Omobolanle, do we have you?
Can you hear me?
Very
Yes,
well.
do. But can you hear me?
Yes, please.
Okay, so from my own experience, it's not a one size fits all and it's multifactorial. It's not enough to present early. You also need to have necessary facility and the expertise to actually give a good outcome to patients. So to start with, patients do actually need to present early because these factors actually influence the prognosis as well as the outcome of treatment. When any patient or any individual notices anything abnormal, the first thing is to present early for checkup. Following that, for which we would have necessary investigations to confirm the diagnosis by doing a biopsy and sending for a histology report to confirm the diagnosis, because not every lump is a cancer. And thereafter, we request for some investigations to actually determine the extent of spread. So the stage of the disease would actually be an important factor to prognosticate and also determine the outcome of the patient's survival, whether the patient is going to survive the treatment or the patient is actually going to get cured. So if it's an early disease, meaning when the cancer has not spread and is confined to the breasts, using the breast cancer as a case study, there's a high chance of survival and cure. There are different options of treatment of cancer. Managing cancer requires a multi-modality approach, which involves not only making the diagnosis and determining the extent of spread, but also making use of other modalities like surgery in case of early disease, or with the use of chemotherapy, which are drugs that helps to kill cancer cells in case of advanced diseases or even in metastatic settings when the cancers have spread. Not only that, we also make use of what we call some hormonal therapies, directed therapies, depending on the subtype of breast cancer we are dealing with, as well as the use of some targeted therapies as well. Also to note is the fact that there is also a role for radiotherapy in some certain circumstances if the indication permits. So with advancements in medicine over a period of time, radiotherapy has actually played a huge role in the sense that we now have more directed precision, towards the treatment, such that we have radiation being directed only towards the cancer cells, while protecting and preventing delicate organs or critical organs at risk, protecting them against the radiation aspect. It's also important to note that cancer care involves a multidisciplinary approach, meaning there's no one size fits all approach for every patient. So treatment is usually individualized, and at the end of the day, the outcome or prognosis will be dependent not only on how early the patient presents, but also on the fact that patient also has good prognosis in terms of the extent of spread of the disease. And the major factor, or most important factor I also want to talk about, is the cost of care. Everyone knows that cost of cancer care is expensive, is on the high side, and in this part of the world where our health insurance schemes do not usually cover for cancer treatment. So the burden is majorly on each individual, and there's so much of out-of-pocket payments. So which from my experience is usually a stumbling block towards getting patients treated at the right time and using the rightful resources when needed.
Right. Thank you very much, Dr. Omobolanle. I'm going to move to Dr. Olumide, who's our general surgeon here. Looking at it from the angle that, timing is essential, just like Dr. Omobolanle mentioned. From your experience, how does the stage at which a patient presents influence the surgical option available and also their long-term outcomes?
Thank you so much for the question. Now, to get this clear and known by all, it is very, very important to know that timing is key. Timing is key, and thanks to the oncologist in the house, she has made my job easy. The early presentation goes a long way in determining how to tackle the problem at hand. Now, we are talking of cancer. Cancer starts at a spot in the body, but what makes it cancer is not staying at that spot where it started. From that spot, it spreads to every other part of the body. So it means somebody that came in early enough to meet the team for care, it is very likely that we are going to meet that condition at the initial spot it started from. Let that be the bone, let that be the heart, let that be the liver, let that be the brain, whichever. Wherever the cancer started from, if that is the stage in which we are catching it, in which the patient presented, called the early stage, then it influences our care. Let me just give a short example so I don't waste time. If there is a burglar, a thief in a big compound, and they said somebody has burgled at this spot, as long as it is clear that it was immediately that thing occurred, that the alarm was raised, it's very likely that that person is within the same compound. So if you give an announcement that the law enforcement have surrounded that compound, the chances that you're going to catch the burglar is very high. But it's a quite different scenario when the burglar has scaled the fence, is out to town, and has almost reached like 2 or 3 bus stops away. Now, if you call the law enforcement to surround the compound, you are wasting your time because the deed has been done and the culprit has almost left your compound. So it's the same thing. So with us, timing is key. I won't want to belabor us with technical terms, but there's something we call stage. And when we talk of stage in any cancer, it's trying to grade It's trying to assess the situation. How severe is the problem I have with me? You have your child and you want to grade how well my child did in the school, in academics. You look at the grades. Is it an A student? Is this an F student? Whichever. So for us, it's a stage 1 to stage 4. Stage 1 is the earliest stage, and at stage 1, for most of our cancers, we report intervention. Any of the interventions you give. Is it surgical? Is it medication with chemotherapy? Is it radiation? Is it immunotherapy? Every option we have. Any of those options that come in at stage 1, which is early presentation, can give treatment or cure as high as 80 to 85% for almost any of the conditions. But for us to give that recommendation that this is something we can attain to the patient, so we don't build a false tall order, that patient must present early. So timing is key. So what is the use of early timing to me as a surgeon? I'll speak for myself. It gives me a better treatment option. One of our very, very good treatment options is either surgery to get everything out at the spot. We will do something called radical procedures. It means I will take the organ of source and cut some things around it to make sure that I have that thing out wholly in my hands. Another thing that can also be very, very effective is radiation. If I put radiation to that spot and I know that thing is only here, I've done my tests, I've done my reviews. That gives me ample evidence that this thing has not gone to any other part of the body. That is just here. I can put the radiation there. There's a condition we do that for, and that's prostate. If I can diagnose that this patient has an early prostate disease, I will just shoot that beam there. I haven't considered every other thing. I will shoot the beam there, and that thing can just get the entire disease. And for some conditions, the chemotherapy can be the best effort. We're getting this knowledge not by myself, obviously by working with the team. The oncologist has seen my patient, has assessed my condition, has cancelled me on the stop, and we say, oh, Mr. Surgeon, you don't really need to put the knife. This condition is known to be chemosensitive, which means it can respond easily to chemo. Or it's known to be highly radiosensitive, which means it can be easily taken away by radiation. I can only get these kinds of feedback if my patient presented in the early stage of the condition. So if it is very late, then most of these options now become limited. There is a limit to the things I can do. Because remember, in medical care, you don't want your treatment to create further problems. You don't want the outcome of your treatment to be more than the burden of the disease that you are treating. So in a nutshell, timing is key. It gives me better treatment options, and it also gives me something. There's a word we use in our medical parlance called prognosis. Prognosis means what kind of outcome am I expecting? A very good outcome, a very average outcome, or a very late outcome. So timing is key, and that summarizes the point.
Thank you very much, Dr. Lumide. Now over to you, Dr. Adefusi. In cancer care, what role does an anesthetics play before, during, and after an operation? And how does that influence patient outcome?
Thank you very much for the question. So as it's obvious that cancer care is multidisciplinary, and I've had seasoned colleagues speak before me. For anesthesia, as it were, we play like a lot of roles in cancer patient management. Usually, first of all, even before, or let me say, when diagnosis is made, that's after a timely or even an untimely presentation. Oftentimes, they might need to do imaging. They might need to do some investigations, where would come in to provide sedation, to provide pain relief, for those procedures. Could biopsy, could be imaging, could be any other kind of investigation whatsoever that you need sedation and pain relief for. Also, oftentimes for patients that are already on chemotherapy, for example, often I know that's one of the common complications usually of chemotherapy is the fact that they tend to, maybe because of the toxicity or because of the concentration, they tend to cause some thrombophlebitis for a couple of they tend to inflame veins. So usually you would help to secure peripherally inserted the catheters, or also to help to secure central venous access for chemotherapy administration. Also, if a patient is scheduled for surgery and we are invited to review that patient, we would often at review, assess the risk, prognosis also, because that's where the multidisciplinary care comes in. We let surgeon know, well, from what we've examined in this patient won't do well if we take him in for surgery because of so and so things we've noticed at review. Also, we can also advise about optimizing nutrition for the patient, because one of the very common issues we have, especially in this our climb, is the fact that because patients present late, they probably lost a lot of weight. They have not been feeding well due to the side effects of the cancer itself or chemotherapy. So we want to advise on optimizing nutrition. Also, because oftentimes many of the cancer cells proliferate using the body's blood supply, we also want to help with cancer-related anemia. I want them to optimize blood volume, to optimize how can I say it now? To optimize, and also to that will help to plan for the procedure we want to order for, or want to review a couple for many of the tests they've ordered and see how well that fits into our own care for the patient for the procedure. That's before the procedure happens. During the procedure also, we actually and that's thing that we do is we help to maintain physiologic and hemodynamic stability. Oftentimes, because many of the patients that come for surgery, cancer patients that come for surgery, they tend to have progressed. That's based on what I have seen, and based on what is common in our climb, tend to have progressed. So oftentimes they already have low blood volume. They already have an issue with probably their heart or their lungs, maybe due to spread of the cancer outside of the organ of origin. So we also want to help to maintain physiological and hemodynamic stability in that period. We also would choose the right agents. Some agents, like I say, inhaled anesthesia can suppress natural killer cells, while total intravenous can help with preserving their function. So we also want to put that into cognizance. Sometimes we also want to, as well as aside general anesthesia or sedation, we also want to optimize, or also want to give maybe like a peripheral nerve block or an epidural that will help to reduce the stress responses from the body cells. Usually post-operatively also, some patients would need intensive care, which is another place we often come in, because we would facilitate transports from the operating suite to the intensive care unit, and also manage the patient in intensive care, which is what we do. Also, that would help us to keep the organs keep the organs functioning, to treat post-surgical sepsis, to oversee recovery, mechanical ventilation, pending when they are fine to recover. Long term, we also would help with acute and chronic pain management, because oftentimes these tumor cells would often they would cause pain due to compression on the nerves, maybe due to bone degradation and whatnot. So we also would often come in with multimodal pain management strategies to help to manage the acute and the chronic pain in that situation. Maybe combination of nerve blocks with a bit of opioids, local anesthesia, infiltration, and whatnot. All this to ensure that the patient gets proper care during the period before the surgery, during the surgery, and even post-surgery and in recovery.
Right.
So that's majorly what we do. Yes.
Thank you very much, Dr. Adefusi. Now, I'm going to come back to Dr. Abib. Now, let's talk lifestyle choices. Now, to what extent do lifestyle choices influence the risk of breast and prostate cancer compared with genetics, age, and also environmental factors?
All right. Yeah. So in fact, there's if you look at the trend that healthcare is going through now, we are trying to bring out information on wellness, lifestyle medicine, and all that. There are many things we do, we eat, that affect our health. So I'll just narrow it down to cancer itself. Smoking, consumption of alcohol, taking herbal concoction sometimes can, greatly affect many people. In fact, in med school, then, if you are preparing for any exam and they tell you that what's the risk factor to any disease condition, there is a 99% chance that if you mention smoking, you are actually going to get it. You understand? Smoking, consumption of alcohol is a common risk factor that you see in many disease conditions. And in this part of the world, smoking is such an interesting concept because you see on the smoking pack, smokers are liable to die young, and people still go ahead to smoke. So you don't see that on soft drinks, you don't see that on bottled water, you understand? You don't drink water and then the sachet is telling you that you are liable to die young if you consume this. But it's on cigarette packs, it's on different things that people smoke, and yet they still take it. So we'll continue to advocate, right? There are many people, there are many healthcare professionals that are no longer waiting for patients to come down with disease conditions, that are putting information out there. There are many lifestyle choices that we get ourselves involved with that adversely affects our health. You understand? Beyond genetic, beyond environmental condition, like you have rightly mentioned. So I would say smoking, right? From my experience, is something that is common across board. And I'm sure if you ask this question along across many of our specialists that are here, they would also mention the same thing amongst many other lifestyle choices that people are involved with that affect their healthcare or predispose them to cancer.
All right, our viewers and our audience, of course, please do not forget to drop your questions. That's why we have the specialist that we have today on the panel. Whatever question it is that you have concerning this conversation, please do well to drop it, and we'll make sure each and every one of it gets answered. All right, I'm going to move to Dr. Omobolanle now. You mentioned that, cancer treatment as revolved. It's no longer what it used to be. Now, with the evolution of new treatments, what are the new innovations and how accessible are they in Nigeria? And also, what do you think must change to ensure that they become a reality for more patients rather than a privilege for few? Okay. Please go ahead.
Yeah, okay. Thank you for that question. Cancer has actually evolved over the year. Cancer care has evolved over the years, and we have, like I said, cancer treatment involves a multi-modality approach, meaning we have different options for treatments, and this is usually guided by the stage and so many other factors. Okay, and to start with, the use of choice of treatments that we usually give cancer patients ranges from use of hormonal treatments to chemotherapy and then targeted therapy. In the past, it was just restricted to the use of chemotherapy, which of course certainly comes with a lot of side effects. And of course, with over time, we've moved on with having to give patients some medications to help curb or control those side effects, as it were. So if I have a patient, whenever I have patients that require chemotherapy, we usually give medications to help prevent those untoward side effects. Chemotherapy are basically drugs, to mention, that helps to kill cancer cells. But the way they work, the way it acts, it not only affects cancer cells, but also affects cells that behave the way cancer cells behave. What do I mean by that? Cancer cells divide very fast. So there are some normal cells in our body that do tend to also divide very, very fast. And that's the way God has created those cells. Example of such cells are the hair cells. For men, you will agree with me, if they barb their hair this week, by next week, what happens? The hair grows back. Cells like that, the cells of the skin cells, the cells lining the throat, the intestine. So all those cells are also equally attacked along with the cancer cells while using chemotherapy. So that's why majority of times patients do come down with side effects. But we have drugs to help control those side effects. So we give them drugs to prevent vomiting, to prevent stooling, before they commence the treatment. We give them drugs even after completion of the treatment. One of those cells that usually also affected are the blood cells, the white cells that that helps to fight against infection. So we give them medications to help boosts their immunity even after the administration of the chemotherapy.
All right.
Not only that, is with the advent of targeted drugs, which don't act like chemotherapy. Chemotherapy attacks both the good and the bad cells. But with the advent of targeted therapies, they are now more directed towards the cancer cells alone. So you don't have untoward side effects like we do have with the use of chemotherapy. Radiotherapy has also, which is also an option of treatment, it has also evolved significantly over the years. So we have modern techniques like intensity modulated radiotherapy, what we call the IMRTs. We have the stereotactic radiotherapies and some other adaptive radiotherapies. So amongst everything I've mentioned, in Nigeria today, there's access to all these treatments or different options of treatments, from the chemotherapy to those targeted therapy up onto the radiotherapy as well. So we have cancer centers, in Nigeria, although they are still not enough because we are beginning to see an increase in trend of the incidence of cancer. So I won't say that we have enough facilities for now. And even for the specialists, we are still in single digits. We are still in few numbers. The patient's doctor ratio is still, gap is still huge. So the facilities are available. These targeted drugs are available, but they are not enough.
All right.
And one major thing I also said previously, sorry to mention, is the fact that it's not enough to have access. How about the costs? The cost of care is one major factor that prevents majority of our patients from, accessing those facilities that are available. The cost of care is huge. Patients can barely feed, let alone purchase and procure these medications when prescribed to them, or even access those targeted therapies that cost, millions of naira.
Thank you very much, Dr. Omobolanle. I must say your contributions here, and this is to all the doctors, have been really, really insightful. But throughout our conversation, our audience has been, or they have been engaging with us actively, and we've received a number of thoughtful questions. But before we get to answer their questions, we'll go on a quick break. When we come back, we attend to the Q&As. Do stay with us. Nigeria records an estimated 269,109 prevalent cancer cases over a 5-year period, with breast cancer accounting for more than 38% of all female cancer diagnoses and prostate cancer making up 30% of male cancer cases. Your health is your greatest asset. And that's why Business Day Television invites you to our monthly health webinar, where we bring vital health conversations closer to you. Join us Thursday, 9th July, as seasoned medical experts discuss the cancer conversation, prevention, early detection, breast and prostate health. Gain practical insights, ask your questions, and learn how early action can save lives. Because every life matters, every health conversation counts. Scan the QR code to register and be part of the conversation right here on Business Day Television.
As Nigeria stands at a critical turning point, we move beyond the conversation of mere survival. This year, Business Day presents the 2026 edition of the CEO Forum, themed from stability to shared prosperity. Join the nation's most influential CEOs, policymakers, and business leaders with keynote insights from Taiwo Oyedele, the Minister of Finance and Coordinating Minister of the Economy, and the Central Bank Governor, Olayemi Kadoso, alongside a powerful lineup of voices shaping Nigeria's economic future. Happening on the 16th of July 2026 here in Lagos. For more information, call Uchenna on 0809 645 3535 or Shegun on 0812 024 3167 or Daniel on 0802 756-4653. This is not just a conference. It's where conversations become decisions that shape the future of business.
All right, welcome back. You're still watching Health Matter right here on Business Day. This is our first ever health webinar, and it's really good to have you with us. Before I went on that break, we had wonderful insights from our doctors here who are actually standing as our panel. We're going to be going into the Q&As, the questions. I see all the questions on the comment session on YouTube. And of course, we're going to be answering each and every one of the questions. I'm going to be starting off with Dr. Olumide. Dr. Olumide, do we still have you?
Yes, I'm available.
All right. The first question here says, what is the age that is common to have prostate as a man?
All right, I would plead to refine the question because we all have prostate as males. I'm guessing the person is asking, relating to cancer, at what age do we begin to look for prostate cancer? I'm suggesting that's what, if that person is listening, I'm guessing that's what you intended to ask. By the policy of screening, screening means you don't have a complaint. You just want to come to the hospital to get checked. Am I fine? Am I doing well? From the current national health policy for screening in terms of prostate cancer, any male from the age of 40, I repeat, any male from the age of 40 should come to the hospital to get the blood tested for something called a tumor marker. The tumor marker looks like something that comes into the blood from an active organ. Just to briefly illustrate, when you start a car that uses and burns fuel, you expect smoke to come from the silencer. So in your body, when an organ is functioning, you expect a chemical to enter into the bloodstream. And the one we are referring to in terms of the prostate health is called PSA, prostate specific antigen. Antigen in our world means chemical. So prostate specific chemical, something unique to the prostate. Every male should start checking from the age of 40. Why? We've recorded prostate conditions, cancerous conditions that could start that low. While I was in school several years ago, I thought it was a problem of people in their late 60s to the 70s. Now we record the conditions in the early 50s, in the late 40s.
Right,
so policy says check it when you go beyond the age of 40.
All right. Dr. Mobanale, the next question is for you, and it reads, what are the necessary and compulsory tests to be carried out yearly to detect on time without falling sick? And a follow-up question with that, then family history. At what age can children start screening? Dr. Mobanale, do we still have you?
Hello. Yes, you do.
Can I take it again?
Okay, so the age for screening, so I don't know, there are several screening strategies for different cancers based on guidelines. So I will just maybe give an overview of the common ones. My colleague, the surgical oncologist, has already mentioned that of the prostate cancer. So for breast cancers generally, so if there is if there's an average risk, like every other person without any family history or whatnot, should start screening. If there are no major risk factors, that's what I mean by that, should start screening for breast cancer from the age of 25 years. Routine screening, by that I mean not necessarily imaging techniques. And the reason for that is because we are beginning to see breast cancer occur even in the younger age group, as early as 25 years. So patients should, or generally speaking, women should be, aware of their breasts. So more of breast awareness between the ages of 25 to 39, breast awareness, then clinical assessment of their breast in case they develop any untoward symptoms. I always say that the reason why God has created some things in pairs is so that we can compare one with the other. Just be aware of your breast, knowing what the normal is, so that when there's an abnormal thing, you can easily detect it. Then starting from age 40 to about 70 years or 74 years, is recommended that every woman should go for annual mammogram. Usually the guideline says about 1 to 2 yearly, every 1 or 2 years. That's if there's no major risk like family history or previous radiation to the chest. But if there's a positive family history, maybe first generation, maybe somebody has siblings with breast cancer, or a parents with either breast cancer or prostate cancer, then they should of course go for more intensive screening. And if they are younger than 40 years, they can do a breast scan or even an MRI, since the women are at an increased risk. Then there's something we call genetic testing for patients who have relatives that have breast cancer. They are at a higher risk of coming down with breast cancer as well. So they can go for genetic testing. They should meet with their doctors who will counsel on the necessary genetic testings that there is for them. So also to mention, there's something we call Angelina Jolie effects. Angelina Jolie is an actress who had a positive family history of breast cancer, and of course went through genetic testing and noticed she had one of the gene being implicated, BRCA mutation. There's a risk reduction surgical procedure that can be done, which she underwent, and that gave her a good chance, of survival. And it kinds of like, there's something we call bilateral mastectomy. It's a form of risk reducing surgery to help reduce the risk of the individual coming down with breast cancer in future, as well as also help to reduce the risk of ovarian cancer as well by removing the ovaries. So there are so many screening modalities for different sites of cancer. So the one I've explained now is for breast cancer. For prostate cancer has been explained. Then for colon cancer, usually for average risk, for patients without any major risk factor, it is usually required that we screen every 10 years using colonoscopy or fecal immunochemical testing. So I would just suggest and advise that generally speaking, once an individual is 40 years and above, go to the hospital, let your doctors advise you and counsel you and guide you accordingly. And if you have a positive family history, you shouldn't wait till you're above 40 before you meet with your doctors, because there are different screening modalities for different types of cancer.
Thank you very much, Dr. Omobolanle. Dr. Abib, do we still have you?
Hi.
Yeah, Dr.
Yeah.
Abib, the next question is for you. And this audience wants you to elaborate on the cost of a cancer treatment and what are the initiatives and measures the government, parastatals, and NGOs are also, putting in place to cushion the financial strain on the affected.
Thank you very much for that question. You would pick from when Dr. Omobolanle was giving an explanation that is not enough to really access care. The cost of care too is very important. In any part of the world, cancer care is capital intensive. In fact, it's capital intensive for all parties. For the healthcare professionals themselves, cost of training, cost of setting up any cancer treatment facility is on the high side. For the government too, it is expensive. For the patients, most importantly, it is very expensive. A good way that we can cushion this effect is for everyone. I think everyone in the country should have an health insurance cover, right? Either from your employer or one that you have created yourself. And if there are family histories that, that is in keeping with, if you have a family history of any cancer case, it will be good to speak to your insurance provider and see that the coverage you have covers cancer care. That's the first thing that we can do as individuals. Then as the government, of course, the government is doing their bit. There is a lot of social insurance schemes that are relatively affordable, like the Ilera Eco scheme, using Lagos State as an example, amongst others. So we can ensure that we make this insurance to cover cancer care, because it's something that is important. You need to be sure what your health insurance actually covers, not just assume that it can cover cancer care. Because like I rightly said, it is capital intensive. What can NGOs do? Of course, NGOs can advocate. There is a room for. Most times, it breaks my heart when I see people come online and try to crowdfund money for people to, get treated for any form of cancer or the other. But it is what it is in this part of the world. That's an economic reality that we have to face. But what we can do is to continue to advocate. What health insurance can do is that it can prevent people from facing this untold financial hardship, or what we call financial catastrophe, whenever they want to access healthcare. And it helps a lot if you go to systems where there is no limit on economic access for care. It is easier for patients to get tested early, to get their treatment on time, because they don't have to worry about looking for money to pay for this test, to pay for these drugs, amongst others. So in a nutshell, we need insurance to cover cancer care. We need it to be affordable, and we need government to help with that.
Thank you very much, Dr. Abib. Now, Dr. Adefusi, do we still have you?
Yes, we do.
All right. So, one of the questions here, he or she is asking for a friend, and they said, or he or she said, I have a friend who said her breast is very thick and full of hard parts. Can this be an indication of cancer?
Well, like Dr. Mbolanli had mentioned previously when she was talking about investigation, when they asked about investigation and diagnosis, it's the fact that, and even when she's talking about timely presentation, is that she mentioned that even when you present timely to the hospital, especially when you have done the self-based examination and then you notice that there are a couple of lumps, and then maybe it feels full, it feels hard. When you get to the hospital, the first thing they do, based on expertise, is to maybe aside history examination, they run a couple of investigations, of which one of it could include a biopsy. So what the biopsy now does is to help you check what kind of cells are these. Are these malignant? Are these benign? So because usually a cancer diagnosis cannot be made until when we know, or let me say, yes, you cannot say that the patient particularly has cancer. That's the word. Or let me assume in this case, when we mean cancer, I'm talking about malignant or tumors that can malignantly proliferate, not benign tumors or not benign growths. So before you can say with all confidence that this person has a cancer, then you have to have gone through the proper steps of diagnosis and investigation to be able to determine what kind of cells are involved or are particularly included in that particular breast organ, and then to now determine if these cells are malignant or benign. So if if it's just to remove the lumps, or you might have to go some step further to do maybe radical mastectomy and what have you. So I think that should help.
Thank you very much, Dr. Adefusi. I'm coming back to you, Dr. Olumide. Do we still have you?
Yes, I'm here.
All right. This person wants to know the factors that are involved in making some patients survive cancer, whether breast or prostate, while some patients don't survive.
Okay. Factors that determine survival are multiple. It's not just all cast in stone that is just one thing, but there are many factors. Let's just run through. First is that how timely did this person present to me? Like I mentioned earlier, if the patient presented at a condition or at a time at which the condition is in the earliest form, that person stands a better chance. Like I said, that's like a stage 1. Some even say stage 0. Stage 0 is something we call pre-malignancy, before the cancer actually develops. But if somebody presents early to me and it is a stage 1. I'm talking of a success rate of any of the applied condition, any of the applied methods of treatment, surgery, hormonal, chemotherapy, radiation, as high as 80 to 85%. Another thing is this: what's the age of the person presenting to me? Am I treating a young individual, a middle-aged person, or an elderly person? Knowing that as the age scales up, the chances of survival, the physiological, which means the innate strength to bear with the treatment, is declining. So younger people will do better on the intensive care being given. Older people may not be able to do as much. In fact, I may not be able to do as much extensive procedures or give extensive medication. Another thing, comorbid. When we say comorbid conditions, it means what other adjoining sicknesses this person may have. So I have a patient, let's say prostate cancer. That's why the patient presented to me. But this patient is also a diabetic who is not well controlled. This person is also a hypertensive who is not well controlled. Or this person has something called an immunosuppressive illness, a condition that affects your immune system. So let's talk about HIV, AIDS. Or patient has another condition that is battling the body, like hepatitis, and is already causing a problem in the liver. So by the time you have all these things happening alongside, survival of this patient is not so good. I also spoke of stage. If a patient comes to me in an early stage, the outcome is good. But if a patient comes to me in a stage that is advanced, like a stage 3, stage 4, for which the condition has spread to many other parts of the body, no matter how good, no matter how effective the type of treatment I want to give could be, this patient stands in risk of becoming worse if the outcomes of my care is presenting with a lot of side effects. So by the time we look at this, I may not be able to give the exhaustive list of all the things that would determine survival, but one of the things that we know is that, okay, then another thing is the reaction to the patient to the reaction of the patient to the kind of medications I'm giving. There are some patients that will just react to many things. Now the option of medications that can be used in care. So there are a lot of factors. Rather than pushing it down the throat of our patients that this factor can make it bad, this factor can make it bad, we hammer on the most important, and my colleagues have done a splendid work of explaining that. Let the patient have a good screening culture. You don't need to be sick. You don't need to wait for a symptom. Make sure you attend your screening. In most cultures, in most government jurisdictions, it's yearly. Every year. Now, it's not as if every year they will run the entire panel of examination from A to C. But the ones that are checked yearly, the ones that are checked 2 yearly, 5 yearly, 10 yearly, everything they are there on the screening panel. Attend your screening care. There is partner with the program we are doing today, One Health, does that very, very well. At the clinic, that they see the patients, they run these kinds of tests, they refer to the specialist early on time. So there are a lot of these factors that are there, but we encourage our clients, we encourage our patients, present early. Don't wait until you have symptoms. Ensure you are screened according to time, and whenever you notice anything, ensure you get the proper referral to the specialist on time for adequate intervention. Thank you.
All right, thank you very much, Dr. Lumide. Coming back to you, Dr. Omobolanle. Now, a very interesting question here. This person wants to know if it is dangerous for one to get breastfed from a cancer patient.
Yeah, thank you for the question. It's a very important question, and I'm happy someone asked. Okay, so to start with, I will just answer the question and by clarifying some details. I will assume some things from whoever asked the question, although it's not detailed, that every cancer patient, depending on the stage and the type of treatment that the patient is on, and also depending on whether the patient is currently on treatment. So there are factors to consider before saying a patient can actually breastfeed a child or not. If the cancer patient has been diagnosed with an invasive disease, so there are different types of cancers, breast cancers to be precise. It could be invasive or non-invasive. By invasive, I mean, let's make a similitude. Imagine you have a balloon filled with water and you have another two balloons filled with water. One of the balloon is perforated and the other one is not. So if an invasive breast cancer is a cancer whose balloon has been perforated, while a non-invasive breast cancer is a breast cancer that still has the balloon intact. If you place both balloons on the table and eventually decide to discard them, you will notice that the table where you have the perforated balloon will be wet, while the side where you have the non-perforated balloon will be dry. So that means that whatever content within the balloon can still spill. That makes it invasive. So I'm just explaining that. So if you have an invasive breast cancer, the patient will most likely undergo what we call chemotherapy. And once the patient is on chemotherapy, most of these chemotherapeutic drugs are what we call teratotoxic. They are teratogenic, meaning they can affect the infants, they can affect the baby, and we don't want that. So while giving the patients that form of treatment, we advise them not to place the patient on any form of breastfeeding. So now for the non-invasive breast cancer, which everybody will just say, oh, I have breast cancer, I have breast cancer. For the non-invasive breast cancers, we don't treat them with chemotherapy. We treat them with other modalities of treatment. So for such individuals who are not on chemotherapy, they are still permitted to breastfeed their babies with the other breasts.
Right.
So that answers the question.
Yeah, Dr. Omobolanle, this audience specifically asks that you answer this. And his question is there any role the trado medical practitioners play in the treatment of chronic cancer?
All right, I get to answer these questions a lot, and it's interesting because I guess this is one of the reasons why majority of our patients present late. It's not that they don't pick it early, but like I said, cost is an issue and some degree of trust. Cost in the sense that they get easy access towards these trado medical individuals even faster than the doctors, and they most times believe so much in them. And at the same time, these trado medical treatments are usually cheaper than our orthodox medicine, the chemotherapy, the surgery, the targeted drugs, or radiotherapy. So to answer the question, and I always put it to patients, if these drugs truly work the way they always claim it does, don't you think those that actually have it would have made a lot of money? People would have come out. Nobody wants to take chemotherapy. Nobody wants to spend so much on cancer care. And that's why I say that before the advent of all this chemotherapy, there were so many trials that had been done to actually confirm if truly these chemotherapeutic agents or the targeted drugs actually work. But for these tradomedical treatments and all that patients do undergo, they don't undergo such rigorous trials like those chemotherapeutic agents. So there is no guarantee. At least I've not seen any patients that these treatments have worked for. So patients end up wasting their money, wasting their time, and by the time they present to us, they present with advanced disease or even with metastatic disease, meaning the cancer would have spread. So I want to state it here clearly today that please, whenever you notice anything, any untoward lump or anything unusual in your body, don't go for the tradomedical first. Seek medical attention first, and then you can be guided by the specialist. There is no role for tradomedical treatment in the treatment of cancer, and it has not been shown to give any form of cure or any form of relief whatsoever to any of the cancer patients.
Thank you very much, Dr. Omobolanle. Over to you, Dr. Abib. Right, this audience wants to know if breast cancer is hereditary, and also this audience also wants to know what role phone devices, AirPods, electronic devices in general, what role they actually play in one getting cancer.
I'm going to start with the second question. I could have placed a bet that it was probably my parents that slipped the second question for the audience. It's one of the many misconceptions they have about cancer care and all that. So there's no, as of today, verifiable evidence that our phones, right, can cause cancer. There's no verifiable evidence as of today. Yeah, there are exposure to radioactive particles can cause cancer, definitely, but not the one from our phones. So if you go to, for example, if you go to the hospital where they do x-rays, they will tell you some areas are restricted, and you see this sign that has yellow and black on it, right? So that place emits a lot of radiation and it is harmful to you. That's why they tell you not to go there. So your phone does not emit that level of radiation. I want to be careful to say that today, because technology is very interesting. They can build crazy stuff tomorrow. But that today, our phones, our laptops, they don't emit that enough radiation that can cause cancer as at today. So to answer the, I think, like, remind me of the first question again.
Is breast cancer hereditary?
Hereditary, yes. Dr. Omombolale mentioned it. Many other people mentioned it here. That if you have a family history of breast cancer, it will be good to get tested early. Most importantly, start with self-breast examination. You can also see your physician and let them carry out some tests for you. Yes, part of the risk factors for breast cancer is a positive family history. So positive family history here, your mom, your grandma, your sisters, basically first degree relative, even second degree relatives too. So if any of them have breast cancer at any point in time, it will be good to have it at the back of your mind that you might have it. So the best way to find out is going to the hospital and do some tests. Like your physician will carry them out and then will interpret the result and let you know how to manage that.
All right, thank you very much, Dr. Abib, Dr. Temiloluwa, Dr. Olumide, and Dr. Omobolanle. Thank you so much for sharing your knowledge with us. All right, I'm sure we couldn't take all of the questions, but ways that we can actually help our partner, Axamazet, they partnered with BusinessDay to, make this webinar a success today. You can actually, get their HMO, their Axamazet HMO, and, check it covers cancer for all our health, and you can actually plan to enroll. They have their offices in Victoria Island and also Ikeja. Whatever package you want, they are there for you, because at the end of the day, your health is their priority. And of course, if there's one message that we've heard consistently today, is that cancer is not always preventable, but many cancer can be detected early and treated successfully, and can also be managed with better outcomes when people seek help promptly. Awareness, regular screening, and timely medical attention can truly save lives. So on behalf of BusinessDay Television and our sponsor, One Health by AXA, I would like to sincerely thank our distinguished panelists and everyone who joined us online and participated through our questions. I am Deborah Eze. Thank you for watching. Stay informed, stay healthy, and we'll see you at the next edition of Health Matters webinar. Goodbye.